Today we're going to talk about soft tissue and musculoskeletal ultrasound. It's a relatively long lecture, so we'll probably have to split it up into two, one soft tissue and then one MSK. Let's get started. I have no disclosures. We have some objectives in soft tissue. We're just going to give you an introduction to some topics. We're going to try to differentiate between normal and abnormal tissue. Then I'm going to identify cellulitis, what that looks like, identify and quantify abscesses. I want to show you what free air looks like in case you can see that. And we'll identify some foreign bodies and talk about some strategies for extraction. On the MSK side, we'll identify some subtle fractures and some not so subtle fractures. Teach you how to evaluate for joint effusions and why you should do that. And also how to evaluate for tendon injuries and tenosynovitis. So let's start with our soft tissue first. When tissue goes wrong, let's jump right in. So first, let's look at normal tissue. You want to look at normal before you look at abnormal. The top left video clip is some normal MSK and soft tissue with a lot of depth. So the majority of the image is taken up by muscle right there in the middle, and the soft tissue is only those layers up at the top. The bottom image is a still image that's zoomed in a bit with decreased depth to kind of delineate some of these layers. So the first most superficial layer is the epidermis, and then right below that, the hypoechoic strip is the hypodermis. That's where the dermis subcutaneous tissue is, and that's where cellulitis will occur. Below that, you have the deep fascia, and below the deep fascia, you'll have a muscle layer. And below that, you'll often have these deep vessels. This is actually my carotid artery, and that's why you see a measurement there. I'm messing around. And then below that, you often have additional muscle, fascia, or soft tissue, and you'll see bone. Let's take our first case. We have a 45-year-old female. She presents for worsening redness, swelling, and pain in her medial right thigh. There was a mild amount of purulent drainage yesterday that has now resolved. You can see her leg there. So you decide to do a bedside ultrasound, and this is what you see. So if you've never seen this before, just compare it to the previous slide. This looks very different. That whole top soft tissue portion that's on top of the muscle, you've completely lost those clean linear layers. Now it looks very enlarged. There's areas of hypoechoic, anechoic, hyperechoic areas where you see inflammation, and that's cellulitis. And then what's the technique for doing this? You got to use a linear high-frequency probe, ample gel, because these areas are often tender for patients. You want to look at the superficial structures, but you also want to look deep because you don't want to miss an abscess or something like that. View everything in two planes, both longitudinal and transverse, again, because you don't want to miss an abscess. And then you also want to apply color. We'll talk a little bit more about why you do that. So here's some additional examples of cellulitis, and we call this cobblestoning. And it's for that same reason I just talked about, where you have these areas of both hyperechoic and hypoechoic regions, and creates this stone-like cobblestoning appearance. Notice in the picture on the left, it looks like pretty much normal tissue, but then as I scan across the cellulitic portion of the patient, you see obvious cobblestoning at the top of the image. The right images are more obvious, where you just have this cobblestoning at the top of the screen. That is classic for cellulitis. The only time where this can fool you is that if the patient has subcutaneous edema for another reason, say if they have congestive heart failure or they have chronic kidney disease and they just have swollen extremities, it'll look very similar to this. And then you've just got to use your clinical skills to see that it's erythematous, it's warm, it's all consistent with cellulitis as well. There's your cobblestone. So remember cobblestoning. Now let's compare that to these images. These look much different. Of course, these are abscesses. Whereas you just had cobblestoning before, now you have distinct collections of fluid and complex fluid, which is pus. On the left image, you just have some cobblestoning, and then as you scan through, it turns into an abscess. That's why it's important to scan these patients in entirety. And on these right images, you can see these are complex abscesses, especially the one on the bottom with lots of gross pus inside. So these patients, need a different treatment, not just antibiotics. They need to be healed with steel. Now, sometimes there's so much pus in these pockets, in these abscesses, that it looks like solid tissue. And if that's the case, you just want to give a little bit of pressure. I mean, this can be uncomfortable for patients, but give a little bit of pressure and you'll see these abscesses kind of swirl around. We call this a swirl sign. That pus will just kind of move back and forth. Now, there's something to look out for here. It's not apparent or obvious if you just look at this image. It just looks like a typical abscess, correct? So one thing I said earlier is you may want to use color, and the reason is because you don't know all the time where the vessels are, because an anechoic looking vessel, you may totally miss that because it's next to an anechoic abscess. So here there's clearly vessels, 1 or 2 vessels, right next to or in the abscess. Now I can plan my IND safely and not cut those vessels. If you have an endocavitary probe collecting dust, you can use that for abscess identification as well. So I don't know if you can guess where we are in the patient, but this is an endocavitary probe that's inside the patient's mouth and reviewing a peritonsillar abscess. So that big collection of anechoic mixed tissue echogenicity at the anterior portion of the image right here, that is a large peritonsillar abscess. And those things that have flow right behind it are the vessels, the carotid arteries back there. So you can see where the carotid artery is. You can see that there's an abscess, not just cellulitis. You can even use this during your IND or needle drainage if you desire. There's your abscess, there's your carotid artery. Now don't be fooled. Some things look like abscesses, but they're not. Any idea what these are? They look like 2 eyes and a nose staring back at you. But those are lymph nodes. Lymph nodes look like tiny little kidneys in that they have a sort of hyperechoic center and then hypoechoic area around it. But that's not an abscess. You don't want to cut into that. Now, what about those hard to reach places like fingers and toes? These can be really hard to image, and we often want to know whether it's just cellulitic or abscess or they have a foreign body. So how do we get around this problem? So one strategy is to use a water bath. These ultrasound probes, they're waterproof. You can just put a patient's hand or toes into a bucket of water. You have a perfect acoustic window, and the images look amazing. So here's an example. All that anechoic fluid swirling around at the top of the image, that's water. We're in a water bath. And then we have a person's foot here, and you can just see that there's a clear abscess that we're scanning through and some cellulitic areas around that abscess. And it's easily identifiable in a water bath. Let's just take another case here. This is an IV drug user that came in to see me. He was attempting to inject into one of his veins here, and it looked very erythematous, swollen. He was in a lot of pain, sort of out of proportion. I was concerned about him. So I had a suspicion for abscess and cellulitis, and I see some cobblestoning at the top of the image, so I already know that he's got cellulitis. As I scan through, I identify that vein that he was trying to inject into. There's no thrombus in there. And then as I scan through, I see this. Now this looks really scary. What is that? So there's a couple options. The 2 things I was thinking about is either, the needle got broken off and he's got a foreign body inside, or there's air, because you have this classic reverberation artifact. That's when these lines get propagated all the way from the top to the bottom of the screen because they're getting bounced back to the ultrasound probe. And so when you see this, you should be concerned that there's air or a foreign body. So I scan through and I see a very gross looking abscess and more air kind of spread throughout that abscess. All those really bright things throughout that abscess, that's air. So I know it's probably not a foreign body. It's most likely a large air collection. And in this scenario, I'm really concerned about necrotizing fasciitis. So identify air, identify neck fasc. Let's talk about foreign bodies real quick. So they can be very difficult to visualize, especially if they're not radiopaque on X-ray. They can be difficult to localize, and you may end up, inadvertently digging in a patient's, foot or hand, and causing local tissue trauma. It may be unclear if the extraction can be even attempted in the office or in the emergency department, and it's uncomfortable for the patient, so you want to do this well. There's high risk for infection, and most importantly, it facilitates and it confirms the removal of those foreign bodies. So look at these ultrasound video clips. On the right, we have a foreign body, and we're looking at it in a short axis on the top right and a long axis in the bottom right. I don't know if you can guess what this image is or what this foreign body is, but it is a bullet. I think now it probably looks obvious, especially that bottom right one. The left image, there's a small piece of glass in the patient's foot. It's at the top of the image, and it creates a nice shadow. You can easily see and identify that in ultrasound. But much harder if you were just going off X-rays. This really helps facilitate finding these and then removing them. I had another patient come in. He was discharged from prison 2 or 3 months earlier. There's a short axis or transverse plane of the foreign body on the left, and on the right I'm getting a partial long axis. He basically said that he had something in his arm and now it was infected. There was pus coming out of the hole where it looked like a puncture wound. And when I looked at this more, I could see that it looked like a long piece of metal or wood that was about 3 or 4 centimeters in length. When I got more history from him, it sounded like it was a shish kebab day in prison, and he had had this in his arm since someone stabbed him with it in prison. I mean, I couldn't believe the story, but if you need one more reason not to have skewer day in prison, here it is. But with the help with ultrasound, I was able to identify this and remove it quite easily. Here's some strategies on how to remove these. If you can't just get it right away, then I recommend injecting with an anesthetic. You can use ultrasound to bring that needle right next to the foreign body. You can inject lidocaine all the way along the track you're going to use to remove it, and then inject lidocaine above and below it and create a little pocket. That'll make it easier for extraction. And then if you can pull it out at that moment, pull it out. If you can't, because it's a challenging shape or so deep you can't really localize it, I would put additional needles in. You may need to use 1, 2, or even 3 to really localize where it is so you can extract it easier. And then you might have to use a scalpel to create some better visualization and create a larger track for removal. I have a video here, but we're going to skip that for the sake of time. So now you know how to treat people with soft tissue infections and foreign bodies with ultrasound. So go get it.